interesting topic today. Uh, is my voice clear? Please, can you confirm that?
Yes.
Very good. So we are here in this webinar discussing neuro-ophthalmic emergencies and when to refer with Dr. Nooran Badeeb. Let me do a quick introduction to the doctor. Dr. Nooran is a professor of ophthalmology in the ophthalmology department in the University of Jeddah. She is board certified ophthalmologist who specializes in neuro-ophthalmology and adult strabismus surgery. She is currently the head of the medical education section at the University of Jeddah. Dr. Nooran received her bachelor degree in King Abdulaziz University in Jeddah back in 2013. She completed her ophthalmology residency in 2018 in the joint program in the Western region of Saudi Arabia. Dr. Nooran completed a fellowship in neuro-ophthalmology and adult strabismus surgery in December 2021 in the University of Ottawa in Canada. She took her medical education fellowship at the University of Toronto in 2019 through 2021. Please welcome with me Dr. Nooran, and you may start. Thank you, Dr.
Thank you, Doctor, for this introduction. And thank you for having me here today. I do hope that this activity is fun. I know neuro-ophthalmology is not an easy subspecialty. It's a bit heavy, and this is after hours. So we do have some interactive segments where we're going to put up polls, and I hope everyone gets the chance to participate in that poll. Okay, and if you have any questions, the chat is open for questions. And then we'll have some breaks after each section to answer some of the questions, inshallah. Okay, Bismillah. So the objective from today's interactive session is basically to recognize the approach to neuro-ophthalmic emergencies. So it's not going to be covering all neuro-ophthalmic diseases, mainly emergencies in neuro-ophthalmic diseases. And the purpose is to be able to initiate appropriate management, especially if this is an urgent situation, and know who to refer to. When you get a patient with neuro-ophthalmic issue, they either have complaint of double vision, oscillopsia, or vision loss, or pupil abnormality. And these are the outlines of the cases today. So we're going to be starting with the double vision, then moving to oscillopsia cases, then vision loss cases, then pupil abnormality cases. Starting with the double vision. With the double vision, we do have two types of double vision: monocular, binocular. Monocular is not my issue as a neuro-ophthalmology. It's an issue of an ophthalmologist. When a patient comes with monocular double vision, they usually come saying that I have blurring of vision. Double vision, I see a shadow of the object, more of a separation. With binocular, it's a separation of image. So something looking like this clock here, or when they read, they see some shadowing of the text that they want to read. So that for the patient, when they say I have double vision or عندي ازدواجية. And what this means is that they might have as simple as a dry eye. They might have refractive errors uncorrected, especially astigmatism can give this picture, or they have lens problems like cataract. And one trick that we can do is that with monocular double vision, if the patient closes one eye or the other, the monocular double vision persists. So we ask them to cover one eye, and then we give them the pinhole and ask them, can you still see the double vision? If it's something refractive error, dry eye, or any other issues of the ocular surface disease, then they're going to say, yes, it's resolved. I don't see any double vision. And for those who are in the primary care or not having any pinholes, as simple as having a paper and a pen, and then you can simply puncture the paper, that's your pinhole, right? And then you can ask the patient to look through the pinhole and see if the double vision persists or it resolves. So with monocular double vision, it's supposed to be resolved. And because I get a lot of referrals with double vision, and then it ends up by being monocular double vision. So the other element which interests us today is binocular double vision, where the patient says that he sees separated images. And then if he closes one eye or the other, the double vision will resolve because it's an issue of eye alignment. So both eyes together opened, they see the double vision. If they close one eye or the other, then the double vision will go away. And with that, we have different types of doubling of vision. So the patient might come complaining of horizontal double vision. So they might have esotropia, as the picture here shows, the eye inwardly deviated, or exotropia, eyes outward deviated. Or they might come complaining of vertical doubling of vision with the hypertropia, as shown here, or hypotropia. So let's talk a little bit about extraocular muscles and their function. We have the lateral rectus, mainly abduction of the eye, so moving the eye outwards, and the nerve supply for the lateral rectus is the abducens nerve. So if we have an abducens nerve palsy, we expect the eye to be esotropic because the lateral rectus is not pulling the eyes outward. And the other is the inferior oblique. So with the superior oblique. So with the superior oblique, the trochlear nerve is the main supply. This is a rung, so it's the superior oblique. And with the superior oblique, the trochlear nerve is the main supply. So if we have a trochlear nerve palsy, then we expect the eye to be supraducted because the superior oblique is supposed to pull the eye down and excite toward the eye. So if we have hyperdeviation, then we suspect that the patient is having superior oblique palsy. And with the medial rectus, the oculomotor nerve is the supply. It adducts the eye in, moves the eye in. And then we have the superior rectus, which moves the eye up, also supplied by oculomotor nerve 3. Infraduction of the eye, inferior rectus, also supplied by oculomotor nerve 3. And then we have the, so this is also a mistake. So inferior oblique is supplied also by the oculomotor nerve 3. So if we have an oculomotor nerve 3 or cranial nerve 3 palsy, what we expect is to see several extraocular muscles being affected. So we have the medial rectus, superior rectus, inferior oblique. So we expect to see limitation on adduction, supraduction, and infraduction. Also because the cranial nerve 3 supplies the levator palpebrae, so we do see ptosis with that, or drooping of the eyelid. And because also it supplies the parasympathetic, which constricts the pupil, then if it's not working, then we have a dilated pupil. So this is pathognomonic for a cranial nerve 3 palsy. Okay, so moving on to simple test for eye misalignment, we have the Hirschberg test. So if you have a light source, even with your phone, you have the flashlight, just put the flashlight and shine it into the pupil. So normally what we expect is that we see the light reflex centered here in the pupil and centered on the other eye's pupil. Let's see some pathological reflexes. So if you have the light reflex centered here in the pupil and the other light reflex is outward deviated here on the outer margin of the pupil, that means the patient is having esotropia. The eye is medially rotated. And then another scenario is that you have the eye, the pupil centered here, the light is centered on the pupil, and the other eye, the light reflex is medially on the edge of the medial pupil. So then we know that the eye is outward deviated. So these are just simple tips. When we have double vision, then we asked ourselves, what is the differential diagnosis usually? So differential diagnosis, we spoke about the nerve, so nuclear cranial nerve palsies, and we're going to have some examples. Then we suspect if the patient is having neuromuscular junction issue, like a myasthenia gravis, and we're having other examples on that. And then is it the muscle? So with the muscle, the most common that we see in the clinic is thyroid eye disease. And we're also going to have some examples. So let's start with the cases, the more fun part. We have a 78-year-old female with an uncontrolled diabetes, presents with sudden horizontal doubling of vision. And this is what she sees basically. So the image separates horizontally. And on eye examination, primary gaze, she has the light reflex centered here, but it's outward deviated here. So we know that she's having right esotropia. When she looks to the right, this eye doesn't go all the way. So she has an abnormal abduction of the right eye. And when she looks to the left, both eyes move fully. So she does have esotropia. And with this picture, what is the most likely diagnosis? Let's see. This is the first trial of the poll, so I hope it works. Okay. Back. Launch. Okay, so you're gonna have the poll. Yeah, let's see. MashaAllah. Okay. Okay. Most of the audience were being attentive to the first part. Okay, so we're gonna, okay. We're still having more that are answering. Some are still thinking. Okay, so we're going to end the poll and let's share the results. So most of you said the correct answer, which is cranial nerve 6 palsy, because we're having abduction deficit and she's a vascular patient, diabetic. So that's probably from the diabetes. Okay, stop sharing. Okay. So what's the next step with this patient who is having a 6 nerve palsy? So identify then urgent referral to the neurology or ophthalmology for assessment. Then when do we need to image these patients? So the only one case that we don't image the patients is if we have a patient who is elderly, having diabetes, hypertension, dyslipidemia, so all the vascular risk factors, and it's an isolated cranial nerve palsy, so we don't have a third or a fourth with it. So in this case, then we don't need to image the patient. If it's a multiple, if the patient is young or the patient doesn't have any vascular risk factors, then we need to image the patient with a brain MRI to rule out that there's no intracranial pathologies like tumors or meningiomas compressing on the cranial nerve. Okay, so moving on to case 2. We have a 35-year-old female, medically free, complaining of severe headache, double vision for 2 hours. We can see here already that we have some clues. The patient is having ptosis or drooping of the right eyelid. And then I marked the pupil here because I want you to know that she's having pupil that is midriatic here. It's not equal size of pupil. And then we know that she has a supraduction deficit, she has an infraduction deficit, and she has an adduction deficit. And abduction is okay. So we know that she's having a third nerve palsy, probably, right? So what's the next step? Let's see. Inshallah, I'll be faster with the pulse as we go along. Technology needs time, so bear with me. Launch. Okay. What's the next step for this patient? Do you refer to emerge for CT, CTA, urgent referral, ophthalmology for assessment, neurology for assessment, order the brain MRI with contrast and follow up as routine? Okay. Okay. So we have different answers. Give it a 1 second, then we'll end the poll. Okay, so let's share the results. So the correct answer is, and I'll tell you why, is referred to emergency for CT-CTA. In a young patient with headache and pain, you want to rule out that there's no PCOM aneurysms. So let's say this patient walks out, goes to the ophthalmology for assessment, and then ophthalmology thinks, no, she doesn't need an urgent CT, or she goes to the neurology as an outpatient, bring the patient tomorrow. So if she's having a PCOM aneurysm and it ruptures, that's game over. So the recommendation is actually to refer her to emergency directly to do CT-CTA. If it's negative, خلاص, then neurology, ophthalmology can assess the patient. But this is just very important for us too, especially when we have the pupil being involved in those cases. Okay, and these are cases of PCOM aneurysms. This is another case, a 29 years old male patient presenting with vertical double vision for 1 year. He had road traffic accident previous to this complaint. And as you can see here, the patient's right eye is hyperdeviated. So I guess we can kind of have a suspect with this complaint. So let's see. I'm going to launch the poll again. So which is likely the diagnosis? Cranial nerve 3 palsy, 4, 6, or it's internuclear ophthalmoplegia. Okay, we're having a competition between two cranial nerves. I'm watching the meter goes up and down. Okay, so I'm going to end the poll. So most of you answered correctly. It's cranial nerve 4 palsy because we'll see why. Because with the third nerve, we said you expect to have ptosis and drooping of the eyelid, pupil being involved. So these are your results. Most of you answered right. With the fourth nerve, it's just a hyperdeviation of the affected eye. As we said, the superior oblique is supposed to pull the eye down, as you can see here. And if it's not working, then the eye will go up. So a hyperdeviation of vertical double vision, especially after trauma, which is the most common cause of a fourth nerve palsy, you suspect a cranial nerve 4 palsy. So what's next? Identify, then urgent referral to neurology, ophthalmology for assessment. So if it's a congenital decompensation of the cranial nerve palsy, then we don't image. Any other acquired cranial nerve 4 palsy, we image because we don't want to miss a tumor or a stroke or anything that is dangerous. So in only the congenital cases, we do not image the cases. We just give them prism and then they're happy with the prism, or we do surgery for them. Okay, this is another case. This is a 34-year-old with droopy eyelid. Double vision starts 2 hours after he wakes up from sleep. So he wakes up from sleep normal. Then after 2 hours, he gets the drooping of the eyelid and the doubling of the vision. And it's towards the end of the day. And you can see that he has a ptosis. He has a bit of esotropia. So with this history, intermittency, we think a way from the cranial nerve 3 palsy, because with the ptosis, we think cranial nerve 3 palsy. But if it's intermittent, then we kind of think of something else, which is myasthenia gravis. So this is a very cheap test. If you have an ice pack, just give the patient an ice pack over the eyelid for 2 minutes. And then if it improves it like this after 2 minutes of ice packs, then this is confirmatory for myasthenia gravis. If it's a third nerve, it shouldn't improve. And also from the history, the intermittent part is very important. The fatigable part is very important. So this is ocular myasthenia gravis. So with ocular myasthenia gravis, usually it's a variable fatigable ptosis, intermittent diplopia. They might have systemic myasthenia gravis, so they might complain of shortness of breath, dysphagia or difficulty swallowing, dysarthria. Towards the end of the speech, they kind of start to break or fatigue, and they have muscle weakness. And ask them to show you the photos when they wake up from sleep. There's no ptosis or no double vision. And then towards the end of the day, they'll show you that their eyelid would manifest the ptosis. So this patient, also after the ice pack test, magic, she improved. So this is confirmatory for the myasthenia, and we basically don't need to image the patient and do all the extensive workup thinking it's a cranial nerve palsy. It's just a myasthenia gravis. And also this patient after the ice pack test improved. So what's next for ocular myasthenia gravis? Usually they need a neurology assessment and ophthalmology consult as assessment, but it's not an emergency, especially if it's just the ocular myasthenia gravis. Okay, another case is a 45-year-old complaining of diplopia on side gaze only, and he has a history of hyperthyroid. And you can see here that he's having the starry eye look, and he is having the eyelid retraction and very angry looking eyes. And he does have the proptosis in both eyes. So with this proptosis, we want to make sure that the patient, because some of them, they come without knowing that they're having hyperthyroid. They did not check themselves. So these patients usually need to be imaged to just make sure that this is confirmatory for thyroid. We see the enlargement of the extraocular muscles. And then if we confirm that this is thyroid eye disease, then refer the patient for ophthalmology if they're having double vision to manage that, and also in the criminology to manage their thyroid status, because controlling the underlying thyroid status will help with the thyroid eye disease as well. Okay, another case is a 55 years old presenting with pain associated with double vision and ptosis for 1 day. On exam, she has, as you can see here, redness. She's having ptosis in that eye, and she's having proptosis as well in that eye. She also have limitation in all gazes of the extraocular muscles. So up gaze, down gaze, adduction, abduction, all limited. So complete ophthalmoplegia. With this complete ophthalmoplegia and pain, we have a lot of dangerous and very serious differential diagnosis: aneurysms, cavernous sinus thrombosis, giant cell arteritis. You can see here pituitary apoplexy, carotid cavernous sinus fistula. So these patients need to go to the emergency straight ahead, and then they need to get imaged. And with this patient, she did the imaging, and she had a carotid cavernous fistula causing this proptosis and limitation. And here we can see the enlargement of superior ophthalmic vein as a sign of this fistula. So let's see what's the take-home messages in all cases of double vision. If you have acute onset double vision, this patient needs urgent referral to ophthalmology for assessment for this double vision. So cranial nerve 4, hypertropia, a ptosis, limited adduction, supraduction, infraduction is a cranial nerve 3 palsy, and esotropia is a cranial nerve 6 palsy. So only with cranial nerve 3, we need to send the patient to the emergency rather than to the ophthalmology as a regular follow-up or an urgent assessment. they need to be seen in emergency for CT/CTA to rule out aneurysms for the third nerve palsy. Then if we have a patient with ptosis like here and double vision that is variable, then we think of myasthenia gravis. This patient, we said, needs urgent referral to ophthalmology and neurology for assessment. And if we have proptosis with double vision, we think thyroid eye disease. And this patient also needs to be seen by ophthalmology and endocrinology for assessment. The last thing is that if we have double vision with ptosis, so the more the P's, the more dangerous it is. So we have double vision with ptosis, proptosis, and the pupil is involved, and it's painful, it's red, then this patient needs to go right away to the emergency because it's not a good sign. It's the pathology, underlying pathology would be dangerous. Okay. Do you want to take like a 2 minutes break or we continue? Because this is the first segment, the double vision, then we're having the oscillopsia. Dr. Mohammed?
I think if there is any question from the audience
Okay.
Regarding the section that we just had, they could write it in the comments for you to answer.
Okay. So let's see. I'm checking the chat for questions. If you have any questions, put it in the chat. Okay, so people are saying continue. So I guess continue.
Yeah.
Then if they come up with questions, we can answer them at the end. So oscillopsia, what is the meaning of oscillopsia? The patient sees shaky environment. So they're sitting here and then something is shaking in front of them. So let's see a case of oscillopsia. This is an 80-year-old medically free, and she was on lithium, complaining of shaking of the environment. Monitor the eye movement that she's having. She's having this eye movement, downbeat. So with the downbeat nystagmus, patients tend to see the environment shaking up and down. So this is called nystagmus. So let's see, this is another case of nystagmus, but this time it's horizontal nystagmus. Still present as horizontal nystagmus. So what is nystagmus? It's a repetitive, uncontrolled eye movements. Patient, if it's acquired, they perceive the environment as shaky, but probably some of you have seen congenital nystagmus, especially in optometry, where they don't have this perception of shaking of environment because the brain has adapted to this movement, so they don't have the oscillopsia. However, when a patient comes with abnormal eye movement nystagmus and they perceive that it's oscillating, there's oscillopsia, they're symptomatic, then you know that this is acquired. And acquired causes can be from medication, like the patient from before, she was on lithium, or it can be CNS disease or peripheral vestibular issues in the ear connections, gives you nystagmus. So let's see if we have a patient with nystagmus, what should we do? So if it's a sudden onset of symptoms, patient is symptomatic, they have ataxia, cerebellar signs, or focal neurological deficit, this patient needs to go to the emergency to be assessed by neurology. If the patient is having chronic symptoms or they're having it since childhood, just refer to ophthalmology or neurology for assessment, but it's not an urgent case. So moving to vision loss. We're going to take some cases. This is the first case. A 75-year-old male patient presents with a right-sided headache, transient monocular vision loss that lasts for 1 month that lasts for 1 to 2 minutes. Like this gets a blackout, and then after 1 to 2 minutes, it resolves. He has been losing weight as he's unable to chew food. He has pain. He has normal eye exam, completely normal eye exam. So with this transient monocular vision loss that lasts for 2 minutes, let's pull and see what's your answer. What is the next step in management? Pull, cut back. So let's see. So do you reassure the patient, send them home because the exam is normal? Do you give them an urgent appointment with ophthalmology? Do you do a stroke workup or put them on anticoagulants and send them home? Okay. Let's share the results. So most of you have answered right. The correct answer is that you do a stroke workup because the transient monocular vision loss for 2 minutes is considered in definition a transient ischemic attack. So the patient needs to be worked up for vascular causes, CT, CTA, head and neck, Holter monitor, look at the heart, look at the neck. And then for vasculitic issues like GCA, ESR, C-reactive protein, and CBC. Okay, so the doctor taking care of this patient discharged him and reassured him, sent him back home. He returns after 1 month only to the emergency with sudden vision loss in the left eye. Vision was no light perception in that eye, and he had a left relative afferent pupillary defect. You can see here that he developed some disc swelling, but it's a very significant pale disc swelling, which we do see with one of the scary diseases in ophthalmology. So with the history, headache, dark claudication, amaurosis fugax, the transient monocular vision loss, and the vision loss, he did have a stroke workup eventually, but it was negative except for high ESR and C-reactive protein, which are inflammatory markers for GCA. So he was diagnosed with giant cell arteritis, and this is a presentation of ischemia, ischemic optic neuropathy in a GCA patient. And the vision is non-reversible with GCA if the patient loses vision. But the purpose of treating them at this point is because we want to preserve the other eye. So what is GCA? It's a temporal arteritis, systemic inflammatory grammatis vasculitis. And it usually affects patients older than 50. So if a patient is younger than 50, then we're going to shift the thinking to optic neuritis. Usually women, Caucasians, high risk of developing irreversible vision loss, as we said. So the systemic manifestations, headache, scalp tenderness, jaw claudication when they chew food, they have pain here, fatigue, weight loss, fever, polymyalgia rheumatica. And ocularly, we need to really pay attention to the patient's complaint of transient monocular vision loss that lasts for 1-2 minutes. Or they can come with a permanent vision loss because no one paid attention to the transient monocular vision loss. Sometimes they can complain of double vision or eye pain. Investigations, inflammatory markers, temporal artery ultrasound, if you don't have the facility to biopsy the patient, or a biopsy, which is more specific. And then the treatment is steroids. And if the patient is needing to be on the steroids for a long time and having side effects, they can be on immune modulatory therapy. Do we have GCA in Saudi Arabia? It's very rare. However, we just need to keep it at the back of our mind. So take-home message from this case is if you have a transient vision loss for 1-2 minutes, it's a TIA, it's a transient ischemic attack. You should investigate it as a stroke. So refer the patient for stroke workup in the emergency if the patient comes to you acutely, or if the patient comes to you with a history of transient vision loss that was before 1, 2, 3 months, then you can call the neurology on-call and tell them, I think this patient needs a stroke workup. Do you want to see them in the emergency, or you want me to send them to the clinic any day of your choice? So they can give you an appointment for that patient. So, and then the patient, of course, needs to see us in ophthalmology because they need the baseline ocular assessment. Okay, another case. So this is a 44-year-old white female presented to the clinic complaining of graying of vision in the right eye for 3 days. She also describes some right eye pain that is worse with eye movements. She denies any other neurological symptoms, past medical history unremarkable. And on exam, the affected eye has a 20/100 vision, and she has a relative afferent papillary defect in that eye. Her fundus exam was normal. Okay, so with the graying of vision, 3 days, pain with eye movement, let's see what you think is the diagnosis. I'm gonna put the pull. Okay, let's start. Is it cataract? Is it optic nerve tumor? Is it an optic neuritis? Is it a glaucoma? Some features in the history and exam will differentiate these diseases from each other. I'm going to tell you later. Okay, so we have a big chunk who answered, sharing the results. So most of you answered optic neuritis, which is the correct answer, and we're going to say why. So optic neuritis is inflammation of the optic nerve. You usually get a vision loss of a subacute onset. So within 3 days, within a week, they lose vision. In cataract, you lose vision chronically. So it's a very slow process. When the patient comes, yeah, since 1 year, 2 years, I noted that my vision slowly is deteriorating. With optic nerve tumors as well, the patient usually have a slower progression of vision loss. Also glaucoma. So glaucoma, usually it affects the peripheral vision rather than the central vision. And at the end, it affects the central vision. And with the demographic of the patient and the age, usually we don't think of cataract because cataract glaucoma is usually an elderly person's disease. And on exam, you should have some abnormality in the glaucoma. So you see cupping of the optic nerve. Okay, so let's move. And then, of course, the patient gets image because we're suspecting optic neuritis based on the clinical history. And definitely she does have an optic nerve enhancement in this image. You can see that it's white and this optic nerve is normal. It's not taking the contrast. Then on the brain imaging, she has the white matter lesions, which goes with multiple sclerosis, optic neuritis. So with optic neuritis, it's an acute, usually unilateral vision loss, periocular pain in 90% of the patient, pain with eye movement, and usually young female, younger than 40 years, usually associated with multiple sclerosis. And in terms of the treatment, they need steroids, and then also they need ophthalmology to assess their visual functions, but also they need, if it's MS, they need neurology to assess them for MS to start the disease-modifying treatment. So take-home message from this case is, if you suspect optic neuritis, then usually the vision loss is acute, subacute, not chronic, and it's over days in a young female associated with pain with eye movement. So in this case, refer the patient to the emergency for management because they need steroids in the acute phase. And then the mainstay of treatment initially, we said steroids. Patients need to be investigated with brain imaging because some are associated with multiple sclerosis. Okay. Another case is a 31-year-old male patient referred for headache, blurring of vision in both eyes. He says that he's been having difficulty seeing cars in the temporal field of his vision. On exam, he has 20/20 vision. So if we stop here and we didn't pay attention to the first part of he has issue with the temporal vision, then dismiss the patient, you're having good vision. Bye-bye. So I did have 1, 2, 3, 4 cases in a 3 years practice that they thought to be normal because they had a 20/20 vision, despite that they're having some issues with the visual vision, as they describe it, and no one thought to do for them visual field, even confrontation visual field. So let's see. So he did have some very mild temporal pallor in both eyes, very subtle, right? You could miss it even in exam if you're very quick clinic or a busy clinic. And then this is his visual field. He's having what we call a bitemporal heminopia. So with the bitemporal heminopia, let's see what you think is the pathology. Sorry, I'm having difficulty putting the poll. Yeah, Bismillah. Okay, yeah. Launch. MashaAllah, everyone is answering very fast, and it's correct answer. Yeah. So we're gonna end the poll, share the results. So yes, it's a chiasmal compression that we're thinking of. It's not a bitemporal or bilateral optic neuritis, because then you're gonna expect that the vision in both eyes are gonna be affected. So it's not 20/20 vision. It's not a refractive error, because refractive errors don't give you a bitemporal heminopia. And it's not a stroke in the occipital lobe, because it's going to be a homonymous field defect in one side. So it's a chiasmal compression. And what happens is that in the chiasm, we have the blue fibers are the nasal fibers that crosses in the chiasm. So they get affected at first from any chiasmal compression, from a pituitary macroadenoma, most common being, or a meningioma, craniopharyngioma in that area, can affect those binasal crossing fibers. So nasal fibers gives visual field temporarily. So that's why we have the bitemporal heminopia. Okay, and this patient, of course, got imaged. And as you can see here, he does have a very large mass in the midline, and it's compressing the chiasm. So this is actually the chiasm, and it's very reflected upwards. And it's actually invading the cavernous sinus as well, but luckily he did not have any cranial neuropathies, just the bitemporal heminopia. So of course, you want to do the hormonal panel, and it was all normal. So it's thought to be a non-secreting macroadenoma because of the size of it. So what's next up in this patient? Of course, the patient needs to be referred to neurosurgery for decompression surgery. Okay. Another scenario is a 24-year-old male presented with sudden dizziness, loss of vision, and headache. You can see here that he's having ptosis. He's having limitation in the left eye in infraduction, supraduction, and also I assume maybe adduction here. So with this presentation, the patient, of course, because we said any third nerve palsy needs to be imaged, right? So the patient was imaged, and the patient was thought to have a pituitary apoplexy. So let's see, what is the pituitary apoplexy? So pituitary apoplexy is if you have a pituitary macroadenoma, usually if it gets necrotic or it bleeds into it, so there's a sudden expansion of that macroadenoma. So that's why there's a sudden decrease in level of consciousness because of the hormonal disturbance, severe headache, and doubling of vision and blurry vision. And the doubling of vision, basically, because we said the cavernous sinus is very near the pituitary gland. So if it expands to the cavernous sinus, it affects your cranial nerves and gives you double vision. And blurring of vision, because upward, if it goes, it's going to compress the chiasm. So that's why they're having blurring of vision from the pituitary apoplexy. And not like the macroadenoma, when it's slowly growing, then causes some vague symptoms in the temporal field. It's more of a sudden onset because of the sudden bleed and expansion. We said bitemporal heminopia, cranial nerve palsies. Investigations, of course, the patient needs to be investigated by endocrine for the hormonal screening, and they need the brain imaging. It's an urgent condition, so it needs to be managed in the emergency room. Luckily, we don't see it in the ophthalmology clinics more often because the patient is having decreased level of consciousness and headache, very severe headache. They come to the emergency right away. Okay, so take-home message from this case is if you have a bitemporal heminopia, like this here, usually it's a chiasmal pathology and the patient needs urgent brain imaging. If the symptoms are acute, so headache, blurry vision, or double vision, refer the patient for the emergency room to be imaged. If it's a chronic symptoms, bitemporal heminopia in the clinic, then just urgent referral to ophthalmology for assessment. Okay, this is another case. It's a 68 years old male, diabetic, hypertensive, and having ischemic heart disease. He comes with a history of stenting on anticoagulation. He's not compliant on the anticoagulants. So he comes with a blurring of vision since 1 month. And he says that he had 2 road traffic accidents in the past month. So that's a bit alarming, right? With the blurring of vision. He had confusion at first. He says that I wanted to go to the mosque, then I found myself lost in the neighborhood. This is at the first when the blurring of vision happened. Then he just went back home, did nothing for a month, and he was driving his car and had 2 road traffic accidents. And his visual field is looking like this. So this is the homonymous heminopia, and it's on the right side, and it's equal. So we suspect in the sudden onset in a vascular patient, old, what? We suspect stroke. So he needs to have an imaging. So he had a CT scan showing a stroke in the left occipital lobe, occipitoparietal lobe. And so if it was acute, within 3 to 4 hours of onset of these symptoms, then maybe we have some time to refer to the neurointervention to give them TPA to dissolve the thrombus. And they say that it might affect the prognosis. However, if it's a 1 month, then we'll see what the patient needs, but it's not a TPA. So for those patients, one thing that is very important, you need to tell the patient that they cannot drive, because I do see patients in my clinic with homonymous field defects, and I'm asking them a trick question, how's the driving? And they're like, yeah, it's a bit difficult, but I'm trying to not go to really long trips. And I'm like, you're not supposed to be driving, you know that. It's illegal to drive. And then I start lecturing them, but we don't have a system to actually say that this patient cannot drive or take their driver license away. So you need to very stress on the patient that they cannot drive with the field defect. Because most of them, they have poor prognosis, so it's static, they don't improve. And in 8% only, they have full resolution. Okay, so how can we test for confrontation, for visual field if we don't have a Humphrey or we don't have the expensive machines? You can use your finger. So make a mark, and then you need to test the patient basically in 4 quadrants. So here, 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 and here. So both temporal, nasal, up and down, and the other eye, temporal, up and down, and nasal, up and down. And if you have a pattern like this, where the patient doesn't see the left eye's temporal field, right eye's temporal field, then this is a bitemporal heminopia. And if you have a pattern like here, the patient doesn't see the left side here, or the temporal from the left eye, and the nasal from the right eye, then you know that he's having a left homonymous hemianopia. Okay, so take-home message from this case is you can use your fingers to do confrontation visual field. You don't need fancy instruments to confirm that the patient is having homonymous hemifield defects. And in acute cases of homonymous field defects, patient needs to be in the emergency room for imaging, so either stroke or a bitemporal hemianopia. So we think of pituitary apoplexy. If it's a subacute chronic case and the patient is well, then you just need to call the neurology, ask them if they want to see the patient in the emergency or they want to see them in the clinic to do a stroke workup if it's a homonymous hemifield defect. Of course, patient needs to be seen by ophthalmology for assessment of visual function and follow-up of that. Another case is a 23-year-old medically free female presents with headache for 3 years. You note that she's morbidly obese. And on questioning, she says that she gained 30 kg in the past 3 years. She's bothered because she's having also vision obscuration in her eyes that will last only for seconds. So just, okay? So it's not minutes, it's just seconds. Her vision is 20/20 in both eyes, normal pupils. And on exam, you find this. So these are bilateral disc swellings or papilledema. And with the normal disc, you can see the margin. Sorry, with the normal disc, you can see the margin here. And with blurring of disc margin, then we consider papilledema. And papilledema can be as mild like this here, or it can be severe and very obvious like this case here. Okay, so with this case, let's put a poll question and challenge you. With this case, headache, vision obscuration for seconds, and papilledema, what is the most appropriate next step? Okay. Measure blood sugar, blood pressure, brain imaging, lumbar puncture. Okay. So we'll share the results. So most of you said brain imaging. It's not wrong. Okay. And then we'll see each option and then we'll say why. So first, we need to measure blood pressure because that's maybe in some of the clinics, you get the blood pressure with the patient's vitals. So you don't need to do it on purpose. But in our clinic, I need to bring the nurse and tell her, measure the blood pressure. Because if this patient is having a hypertensive crisis, very high blood pressure, then they might present with bilateral disc swelling and headaches. And this is not my issue. I need to send the patient to the emergency to deal with the blood pressure, to normalize the blood pressure. If it was normal, then yes, the patient needs to do brain imaging because it might be a cerebral venous sinus thrombosis causing this. It might be also a brain tumor causing this. And for the blood sugar, not so much important in this case in particular. However, whoever said lumbar puncture, yes, lumbar puncture, if the brain imaging was normal, we do lumbar puncture to see the opening pressure. However, without the brain imaging, we cannot do lumbar puncture because sometimes if the patient is having a tumor and having high ICP or high intracranial pressure, you do a lumbar puncture, brain can herniate. So it's a contraindication to do a lumbar puncture in those cases. So that's why we need the brain imaging first. Okay, so I'm going to stop sharing. Let's move to the next slide. So she had normal blood pressure. She was sent for brain imaging, was normal as well. Neurology performed the lumbar puncture after the brain imaging, and it showed the high opening pressure, normal CSF composition. So she doesn't have any infiltration or cells or tumors. So then the diagnosis is idiopathic intracranial hypertension, or IIH, known previously pseudotumor cerebri, known as benign intracranial hypertension, but the new name is idiopathic intracranial hypertension because we don't know what is the cause of it. The symptoms: headache, nausea, vomiting, pulsatile tinnitus. So pulsatile tinnitus is not like the patient, usually when we ask them, do you have tinnitus? They say yes. But actually, I mimic the sound of the pulsatile tinnitus. It's like a whooshing sound. So it's like a with each beat. It's not a sound that we get with ENT or ear issues. And transient vision obscuration, as the patient was saying, for seconds. And it's also because the pressure from the CSF on the optic nerve and the eyes moving causes some ischemia. So that's why it's for seconds that they have this obscurations. The signs: optic disc swelling in both eyes. Sometimes they might have cranial nerve 6 palsy, and they complain of intermittent horizontal doubling of vision. So investigations, we said brain MRI, MRV, and lumbar puncture. Treatment, we need to lower ICP. So first line of treatment is losing weight, because that will reduce the ICP. Second would be management with medication. And in patients who are deteriorating or having vision loss, then they need to go to surgery, either VP shunting or LP shunting, venous sinus stenting, or optic nerve sheath fenestration. Okay, another case is a 44-year-old male, presents with vision blurring over 2 weeks, associated with headache as well, and he's medically free, or he thinks he's medically free. We'll see. So the vision is moderately affected, 20/50, 20/100. He has defective color vision. And he has, in the left eye especially, reduced visual field, and in the right eye, some nasal point superior inferiorly, and he does have bilateral disc swelling. So let's see. In his case, what would be the appropriate next step? And we'll put the poll again, if it allows me to, yeah. Okay. Launch. With measuring blood sugar, blood pressure, brain imaging, lumbar puncture. Okay. Okay. It's slowing down, so we're gonna end the poll. So most said, again, brain imaging. Okay, sure. Eventually he might get a brain imaging, but let's take it simple. We have the blood pressure machine in the clinic. So the next step is measuring the blood pressure. Why? Because we said that maybe the patient doesn't know that he has hypertension, and then he presents with a hypertensive crisis, and his blood pressure truly was, this is a true case. So his blood pressure was 220/150. And basically what we did is we referred to the emergency, and the emergency needs to lower the blood pressure. So take-home message from these cases is, if you have bilateral disc swelling, you need to measure the blood pressure to rule out malignant hypertension first in the clinic, then brain imaging, if it's normal, brain imaging to rule out tumors, cavernous sinus thrombosis, cerebral venous sinus thrombosis. And then if it's negative, then the patient will have a lumbar puncture, and this patient might have an idiopathic intracranial hypertension. So then they need to be referred to neurology for lumbar puncture and treatment, and ophthalmology for observing and monitoring for the papilledema and the visual functions. Okay, so the last segment, we have one case of pupil abnormality and a bit of discussion, then maybe we can take the question at the end. So last thing is the pupil abnormality. Patient in neuro-ophthalmology can present, or someone refers him with pupil abnormality. So this one is one of my patients. She's a 55-year-old woman, medically free, noted that she's having this abnormality in the left eye for 6 months. On exam, she did have a smaller pupil on the left side. So we call it anisophoria, where the pupil size is unequal. But of course, because she has brown iridis, it's very difficult to note that this is a smaller pupil. Okay. So what is the diagnosis? It's a Horner syndrome when you have a ptosis and meiosis in the same side. And the pathology can be from anywhere from the hypothalamus, going down to the brainstem, going up the lung apex and carotids into the eye. So in cases with Horner syndrome, usually we need to image from the head, neck, upper chest. We need to cover the whole sympathetic chain. And usually it's very difficult when you have a Horner syndrome in people with brown iris. You cannot note the smaller pupil if you did not look for it. So with any case of very mild ptosis, tend to have the habit of flashing the light in both pupils, and sometimes it's also very difficult if you don't measure it. So if you have as simple as a ruler, measure the pupil in the right eye and the left eye and see if it's equal or unequal. Because sometimes it's very minimal, the difference. It's just 1 millimeter or 2 millimeters. So with the eyesight, you can miss it. So let's see. Ptosis, meiosis, left eye, Horner syndrome. What would be the next? Let's put the last poll up. And let's launch it. So what is the investigations needed? MRI brain with contrast, Doppler ultrasound, neck, CBC, ESRC, reactive protein, head and neck, upper chest imaging. Okay, so let's share the results. So most of you said head, neck, upper chest imaging, and then the other part was MRI brain with contrast. So because we cannot identify what is the cause of this Horner or localize where is the pathology, is it the head, is it the neck, is it the upper chest, then that's why we usually tend to image the whole sympathetic chain. Because sometimes it's a brainstem pathology, it could be a spinal cord pathology, it could be an upper chest or a upper lung tumor, especially if the patient is smoker, or it could be a carotid pathology, could be a cavernous sinus issue. So that's why we do the whole sympathetic chain imaging. And in this case, she did have an upper lung mass. So this is the significance of imaging the upper chest and saying to the radiology, please include the upper chest in the imaging, because sometimes you don't need to image the whole chest, just as simple as the CTA neck, please image the or include the upper chest. This is a patient with Horner syndrome. We want to see the whole sympathetic chain. Okay, so what's Horner syndrome? When you have ptosis, meiosis, and anhidrosis, this is a triad of Horner, and the defect is in the sympathetic chain. That's why we have a meiotic pupil or a smaller pupil, because sympathetic should dilate the pupil. If it's not working, then the pupil will be meiotic or smaller. And also the sympathetic chain supplies the molars muscle, which is a muscle that gives us a 2 millimeter rise in the eyelid. So if it's not working, that's why you have this minimal ptosis or minimal drooping of the eyelid, barely notable sometimes, especially if the patient is elderly. They usually have a lot of eyelid issues with the the fat prolapse and issues. So sometimes it's very difficult to actually see the Horner. Investigations, we said we're gonna image the whole sympathetic chain. And treatment is treating underlying cause if it's found, because in 50% we do the imaging and it's negative. So we say it's an idiopathic Horner. We don't know why the patient have it. At least we excluded the pathologies. So one thing with Horner syndrome, if a patient presents with a headache and ipsilateral Horner, say this patient presenting with a left-sided headache and a Horner on the same side, this patient needs to be imaged in the emergency room. Why? Because you need to exclude that they're not having a carotid dissection like this patient here, where you see the blood here in the intramural space. For the risk factors, if this patient is having headache Horner on the same side and he's a young patient, usually it's a trauma. So a flash trauma where they have the carotid dissection, or sometimes chiropractors, or if you have this massage and then you have a hyperextension of the neck, or someone who's manipulating the neck in a very aggressive manner, then they might have young with carotid dissection. In older patients, usually they have vascular risk factors like diabetes, hypertension, and dyslipidemia, which gives them a risk for having this dissection. So let's see, take home message for the Horner. If you have ptosis, meiosis, and hydrosis, it's a Horner. Refer the patient to ophthalmology for evaluation and confirmation. If it is a Horner, refer the patient. If it's a Horner and it's painful, patient is having headache on the same side, emergency, at least CT ANEC to rule out the carotid dissection. These are very useful resources for people who want to read more about emergencies in neuro-ophthalmology. Dr. Andrew Lee is one of the pioneers in neuro-ophthalmology. He's a very nice, simple way in writing up cases, and it's very readable. Even if you're not an ophthalmologist, you can read through and get some benefit from those books. And if anyone has any other questions or cases that they want to share, this is my email. And thank you very much for staying this late.
Thank you very much, Doctor. It was very informative and interesting lecture. Now, I think if you don't mind, we can answer some questions. So if anyone has a question, you can just write it in the chat, and we will discuss it. We might start with this question, Doctor.
Okay.
As a doctor of optometry and as optometrists are the majority of the audience, one of the challenging case or situation that we face in the clinic is that when we are suspecting an optic disc edema, a unilateral optic disc edema, that doesn't have like acute like signs and symptoms. Like when patients come for a routine eye exam, then we notice like one disc that is slightly elevated and suspicious. What like are the red flags that we should look up for before like ordering MRI or CT? Thank you.
So it's a very common scenario where optometry would examine the fundus and they note that the patient is asymptomatic but has bilateral disc swelling, and they refer the patient to ophthalmology. When to kind of be suspicious if this is a secondary cause. So first we said measure the blood pressure, get it out of the system. The blood pressure is normal. And some red flags is when you have the vision is not corrected to 20/20, so you have some visual dysfunction, the color vision is defected, and then you do the visual field and you find some points of visual field defect. When I start to lose the function of the nerve, then this is a red flag. Or if you have a disc swelling that is not a grade 1, you have a grade 3, 4, 5 disc swelling, like a very severe disc swelling, then this is an emergency. This patient needs to be seen by the emergency, in the emergency by an ophthalmology. So either reduced visual functions, or you have severe disc swelling, not just like the suspicious disc. Maybe it's just a full nerve. Maybe it's a grade 1. That I would accept a regular referral, especially if the patient is asymptomatic, not having headache.
Okay, that's really great to know. So, is there like any rule of thumb, like the average RNFL in the OCT that we look up for? And like, for example, if we see a certain number above which we should like be concerned and we should refer the patient, is there like some rule of thumbs or cut-off values in this regard?
Usually something more than 140, 150 would be a bit concerning, because the OCT as a tool alone is very nice, but we know that some of the patients have thickening in the RNFL, and then when you examine them, they have normal optic nerves. There's no blurring of disc margin, there's no disc swelling. But if it's more than 150, 160, 200s, then it's a bit concerning that this patient needs to be seen by ophthalmology urgently, or at least within the month.
Okay, that's really great. The other question that I get is like, when should we concerned about temporal polar of the disc? Like sometimes, especially like with the high myopes, or we get sometimes like a temporal polar of the disc. And when should we consider it as like significant and worthy of referral to a neuro-ophthalmologist? And when should we not like pay much attention to it?
So I guess because it's in myopes, you have some congenital deformed disc. So you have the tilted disc, you have the peripapillary atrophy. Sometimes you have the temporal pallor. Sometimes you do the OCT and it doesn't give you accurate readings. So if you're concerned about the temporal pallor, I guess refer the patient for further investigations, at least to get a visual field, and then maybe let the ophthalmologist decide if this patient needs to be imaged to rule out if there's any compression on the brain or not. Because also with the myopes, usually I get referrals because before they do the refractive surgery, someone examines the fundus, and more often they see the tilted disc that is concerning for disc swelling. It's a full nerve, it's a grade 1 disc swelling. And what I usually do is, because they want to clear them up because they want to do surgery, I just let them do the MRI. If it's normal, then we just observe the disc and see if there's any worsening or not, especially if the patient is asymptomatic and the MRI is completely normal. There's no signs of even high ICP. Then that's just a myopic tilted disc, and follow-ups to see it doesn't change. So sometimes we do have to have this further steps to make sure that this is not a pathologic pallor, this is not a pathologic swelling in myopes. It's a bit tricky.
Awesome. The other question that I got is regarding or like asking your opinion in the involvement of optometrists in optical shops and primary care in the screening for uh, ocular disease. Do you support and do you advise optometrists when they receive patient for routine eye exam and sight exam to see the disc and see the examine the eye?
So for me, I would say yes, but it depends on the training of the optometrist, because some are trained to only do the refraction and comfortable doing the refraction. Some are comfortable doing the orthoptic measures of the strabismus or examining the eye movements. So if the optometrist is comfortable and in doing the basic eye check, IOP, the checking the fundus in this context, then yes, sure, why not? It's a good thing, and then it's it's a skill that they need to practice to be able to kind of say, yeah, this is normal, this is suspicious, this is normal. You need to see a lot of normals to be able to identify the pathology. But I would say if you're comfortable doing the examination, yes, why not? I see some question in the chat. Let's see. Regarding myasthenia, can it happen in the beginning of the day? So the ptosis with myasthenia gravis, sometimes it's not variable. But if it's variable and you do the ice pack test in the clinic, it helps to say that this is myasthenia gravis. But sometimes, yes, they have the fixed ptosis and they have the fixed strabismus. So it's not all the time, but it's helpful when the patient says it's worse towards the end of the day, and then you do the ice pack test and it's positive, then that would suggest myasthenia gravis rather than a third nerve palsy. And one rule of thumb, if the pupil is involved, it's not a myasthenia gravis, it's a third nerve palsy if the pupil is involved. How about treatment plan? Not sure treatment plan for what. Why just the third nerve is an emergency? So with the fourth, with the sixth, least likely that you would have an aneurysm compressing and it would rupture. This is with the fourth nerve palsy and the sixth nerve palsy. With the third nerve palsy, we know that we have from other studies that there's a risk that you can have an aneurysm, the posterior communicating artery aneurysm, compressing the third at the first stage, causing the pain and the ocular motility issues. And then it might rupture at any time, causing subarachnoid hemorrhage and very poor prognosis for the patient. They might die. So that's why the third, especially if it's pupil involving in a young with pain, they need to go to the emergency right away to do a CT-CTA. Okay. Can stroke present with wrapped and pale disc? Ideally, no. So with stroke, if you have a retrochiasmal pathology involving the radiation, so temporal, parietal lobe, or occipital lobe, you shouldn't have relative afferent pupillary defect. And at the first stage, you shouldn't have a pale disc. Some studies report after years and years and years of this patient having the stroke. So let's say after 20 years, maybe you're going to have a retrograde degeneration from the white matter, and then you're going to manifest to see some pallor in the disc, but not in the acute stage, not in the first few years of the patient's life. You shouldn't see a pale disc. How can we? Okay. Okay. So there was a question about how to identify if the visual field is a right-sided or left-sided. What I usually do is I put the right-sided visual field, so OD, beside my right hand, and I put it this way. And then the left-sided beside my left hand, I put it this way. So the blind spot here is at the right side, the blind spot is the left side. If the homonymous field defect is coming temporal on this side and nasal on this side, then it's a right homonymous heminopia based on my hand. And then if it's on the other side, then it's a left homonymous heminopia. I might share this slides again because it's a bit vague when I'm trying to explain it this way. Let's go back to the visual field slides. Okay, so in this case, this is the right visual field, and this is the left visual field for the left eye because the blind spot is here in the left side. So then I see this is a right, and the field defect is on the right side, and this is the left, and the field defect is still on the right side. So this is a right homonymous heminopia, and usually the brain pathology is at the opposite side. So we expect a left retrochiasmal abnormality, like this patient, he has a left stroke. If it's a left homonymous heminopia, so the brain lesion is here and here, then the brain pathology is expected to be on the right side. So it's opposite to the field defect. And then let's see if we have other questions. So what if we have optic disc swelling on one side and atrophy on the other side? If we have one eye with disc swelling, one eye with atrophy, this is image the patient. They need to get imaging. Why? Because it could be a Foster-Kennedy syndrome, which is that you have a midline mass compressing on one of the optic nerves, causing the atrophy and causing high ICP. So one other optic disc is swollen from the high ICP. Or it could be a pseudo Foster-Kennedy syndrome if it's negative, the brain imaging, and the patient is vasculopath, diabetic hypertensive. They might have NAO1, old NAO1 in one eye, so giving you the disc atrophy, and a new NAO1 in the other eye with the disc swelling. So that's a pseudo Foster-Kennedy syndrome. But definitely, if you have one disc swelling, one atrophy, this patient needs to be imaged to rule out a tumor. I have a unilateral grade 1 disc edema of 31 years patient with 3 years diabetes with no symptoms, just for follow-up for diabetic retinopathy, but MRI normal. In this case, you might want to do also B scan to rule out optic disc drusen to check if there's no optic disc drusen, pseudo disc swelling. Or sometimes diabetic papillopathy. However, for 3 years and it's been stable, it's least likely a diabetic papillopathy. Okay, when diagnosing ptosis, that's mean the problem in cranial nerve 3 always, never be another cranial. Yeah, so if you have ptosis, that's a cranial nerve 3 palsy, or the other differential is myasthenia gravis. Cranial nerve 3 palsy would involve the pupil. If you have no involvement of the pupil, then you might consider a myasthenia gravis. However, with third cranial nerve, you have the extraocular motility pattern is very obvious. So limited supraduction, infraduction, adduction. It's with the ptosis and the mydriasis sometimes, it's more suggestive of a third nerve. But other differential diagnosis is myasthenia gravis. What is your opinion on functional MRI in neuro-ophthalmology in specific cases? Functional MRI, I'm not sure. I don't have many experience on it, and I'm not sure if they're actually doing it outside the research scope in some of the hospitals, like big hospitals. When should a patient with nystagmus be referred to a neuro-ophthalmologist? If it's a new onset nystagmus and oscillopsia, and the patient is bothered by the symptoms, refer the patient for investigations and for possible management. Or you can refer the patient to neurology as well. If it's a young patient with nystagmus, refer the patient to pediatrics ophthalmology to investigate, because some of them are sensory nystagmus, some of them are motor nystagmus, but peds usually are better to evaluate the nystagmus in childhood or congenital nystagmus. Okay. Okay. So I think we are good. I do hope that I did not skip any of the questions. Yes, I think we're good, inshallah. If there's no any other questions, we can end the session. I really enjoyed this session and the interaction from the audience. And if anyone has any other questions or cases that they want to have an opinion on, I really like if you send me an email.